Okay, guys, so as of last week, we were going to break into groups and do the 3 different breathing patterns, right?
Yeah. Oh, yeah.
And I asked you guys to, each group would take a different breathing pattern.
Right.
And it was either Kussmaul's, Bayat's, or Shane Stokes. Your group was going to demonstrate what that breathing pattern was, right? Then you were going to tell me possibly what disease it was related to, right?
Yes.
And you're going to demonstrate it.
Yep.
So, who wants to go first? We got Kussmaul, Bayat's, or Shane Stokes?
Yeah, I didn't realize that was the groups we were getting into right now.
Yeah.
Okay, go ahead.
Okay.
Yeah.
Because I did Kussmaul breathing.
Sorry. We did.
We did Biot.
Yeah, we did Biot. I thought it was blocked.
Bayat's.
I'm like,
I did
why
do
is
it for a
it
while.
up?
Okay.
Should we do it?
Yeah, go ahead.
Yeah.
How do we?
You want me to be the patient, or you want to be the patient?
I'll be the patient.
Okay.
Okay.
Ma'am, I'm gonna need you to take your gloves off.
Okay, so we're going to do Bayat's breathing pattern.
Yeah, I mean, yes, you.
Okay?
Go ahead. Do your thing.
Okay, I'm gonna be a patient.
Bayat's, not blots.
Do we take my shoes off or do we leave them?
Please do. If you get, you guys, when you get into these beds, please take your shoes off. They do change. We do change the sheets and the covers and blankets and clean them. Okay. So, Bayat. So what is Bayat? That's a good demonstration.
Yeah, that's exactly.
So what did she just do, Cynthia?
So she's actually she's trying to breathe, but she's having difficulty breathing, and at the same time, it's normal.
Sorry. Our friend here slipped.
You're right. It's normal and abnormal at the same time. So of course she's trying to breathe, and she's having difficulty breathing and pausing in the middle of the difficulty of breathing.
Apnea with the breathing. Yeah, it's like 10 to 30 seconds.
Apnea, there's that word, right? Apnea means?
Spontaneous shallow with the 10 to 30 seconds of apnea. And it repeats.
And then, it repeats.
Okay, so it's how long of apnea?
10 to 30 seconds.
10 to 30 seconds of apnea, which is, what does apnea mean?
Absence of breathing.
Absence of breathing, followed by?
Shallow breaths.
Short, shallow breaths. What's the difference between a shallow breath and a regular breath?
It's not deep.
It's not deep. The shallow is not deep at all.
Correct, you guys. The difference is shallow breathing is you're not getting your full tidal volume. Okay? Now, getting your full tidal volume is just breathing normally. It doesn't mean you're doing this. That is more than your normal tidal volume. Okay? So that is a good demonstration of Bayat's. Or blots, as Cynthia would like to say.
I thought it was too.
Good job, you guys.
All caps.
Is there anything else we need to do?
Nope, that was all I wanted. What diseases could Bayat's be associated with?
It's sort of with brain damage. What they've been doing.
Brain damage?
So brain stroke, anything with brain damage, and then opioid overdose.
So a drug overdose.
Opioid, yeah.
Good job. High five it. Who's up next? What do we got? Kussmaul's or Shane Stokes?
Kussmaul.
Okay, Stefan, let's do it.
Sorry, I was aggressive. Here we go. I'm just gonna go ahead and get in bed.
Okay.
Yeah, so pretty much Kussmaul breathing is characterized by a rapid respiratory rate, as you can see.
What do we call that? Quick respiratory rate. Tachypnea. Or you can call it tachypnea. Either or. I'll take either or. Okay, so we have periods of tachypnea.
And then you also have a higher than normal tidal volume, so he's breathing more than usual.
Okay.
And then usually it's associated with severe ketoacidosis associated with diabetes.
Right. So,
Ouch. I don't know how to get out.
so, small breathing is associated. If you guys ever have patients that are in ketoacidosis, they're probably going to end up in small breathing. Okay. So what is it? One more time.
Yeah, so it's tachypnea with also a higher than normal tidal volume, and it's associated with diabetic ketoacidosis.
Right. So it's big deep breaths, rapid, right? Tachypnea and big deep breaths. Okay.
And it could be rapid when they're resting or like when they're moving.
It will be rapid. If they're in ketoacidosis, it will be rapid all the time. Good question. Okay, cool. Good job. Stefan, you did good.
Oh, thank you.
Okay, Shane Stokes.
You're natural at that breathing.
You guys, these are 3 breathing patterns in the hospital you'll probably see a lot. Shane Stokes, here we go. Okay, what'd she do?
Alright, so it's an abnormal pattern of breathing. Starts deep and fast, and then it slowly decreases, and then it's followed by apnea, 7 breathing, and then it repeats.
So what is the difference between that and BIATS?
BIATS is more shallow.
Right. So these two are really similar, you guys. The only difference is this is deep breathing. She was getting more than her normal tidal volume. Okay, but it was rapid. Right? What breathing is this? What is this similar to besides BIATS? Deep breathing, rapid.
Hyperventilating.
Hyperventilating. It's really similar to hyperventilating. What diseases is Shane Stokes associated with? Anybody know?
Yeah, it's
Laryngitis or something? Started with a J.
Tourette syndrome,
Mm-hmm.
Yeah.
and then also has something to do with like cardiac.
Cardio.
Yeah. Like when what's that? I'm trying to remember.
Find my phone.
And it's
Use your
also, like,
resources.
also sleep apnea.
Sleep apnea is a big one, right? Because in sleep apnea, what do we do with sleep apnea?
You stop breathing.
You stop breathing for periods of time, right? And so this is really, this is associated with sleep apnea if it's central sleep apnea, okay?
Failure.
Heart failure is a big one, okay? So, you guys did good. Okay, so when you are testing out on your competency that we're about to go over, you may have one of those breathing patterns. And what do we call a normal breathing pattern?
Eupnea.
Eupnea. Yep. What about lying flat? I'm lying flat, I'm lying supine, and I can't breathe.
It's ortho.
And the only way I can breathe is by sitting up.
Orthopenia.
Orthopenia.
Okay, and then what is the one that I have problems breathing when I'm standing up? You're right.
Platy.
There you go. Okay. So you guys, let's just make sure that we get to know these, okay? Okay. Now the next thing we're going to do is we're going to do our competency on patient assessment. Everybody went through that PowerPoint, right? That big long PowerPoint.
Very fun.
I'm glad you enjoyed it, Stefan. Aw.
It was long.
Okay, so when we do physical assessment, there are 4 things we're going to look at. Inspection, palpitation, percussion, and auscultation. And that was in that PowerPoint. So when you think about inspection, what are you thinking? If your patient is laying in bed, what are you thinking on inspection?
The visual.
The visuals, right? What am I looking at? How's their color? Do they have pitting edema? Are they coherent, right? What else do we have? You can look at a lot of your criteria in your competency Guys, you can do that visually. You can see if your patient has cyanosis. What is cyanosis? Blue. So we have two types of cyanosis, acrocyanosis and central cyanosis. What's the difference? Do you guys know?
Acro is just in the like smaller extremities and the tip of the nose and stuff like that.
Acrocyanosis is your peripheral extremities. Okay? Central cyanosis, just think of it midline. Okay? So where do you think, which population, pediatrics, neonatal versus adult population, which one do you think is going to have acrocyanosis more?
Older. Acro kids.
Kids, right? They're going to have acrocyanosis, especially in your neonates and infants. When babies are born, a lot of them, their extremities are blue. They have acrocyanosis. And when that happens, you know what we say? Just give them some blow-by, they'll be fine. If an adult had acrocyanosis, we'd be worried. So you have to remember with these different types of cyanosis, in the age population, it's more serious than it is in another age population. Okay? What about central cyanosis? If Dusty's laying in bed and I go to do her assessment, she has blue lips, what is that telling me?
Not gonna be circulation going on.
We have some perfusion issues, right? So in an adult, if you have perfusion issues usually leads to what? What's the cause of that probably? The heart, the cardiopulmonary system. Okay? So those are some terms that you have to be used to also. Okay? But that's on visual inspection, that's some of the stuff you can look at. Because I know on your competency, how many criteria do we have there? There's a lot, right? Okay. So inspection, I'll show you guys how to just kind of visually look at stuff, right? Look at your patient and see certain, look at the different systems, okay? Then we have palpation. What is involved in palpation? Do you guys, from your PowerPoint? It's touching your patient, right? So what is that?
You know, I don't know much about it. I've kind of touched on it, like palpitating with your hands, doing something.
Right. So we have some criteria that we have to do. We're going to feel for sub-Q or subcutaneous emphysema. We just call it sub-Q, or it's called crepitus right here. What is that? Does anybody know what that is? No? Okay. If I get a pneumothorax, what's a pneumothorax?
It's you have fluids in your lungs.
I get a hole in my lung, right? The air escapes, and so where does the air go? Yeah, it goes into my thoracic cavity. That's what sub-Q is. It's air under your skin, under your dermis layer. When you palpate your patient, it's going to feel like Rice Krispie treats, like Rice Krispies, okay? When we palpate, we look for tracheal deviation, okay? When you get a pneumothorax, I get a pneumothorax on my right side. I have a hole in my right lung. Air is escaping and it goes up, right? Which way is it going to push my trachea? To the left. So somebody who has a pneumothorax, when you palpate their trachea, it's going to, what we call, have a left tracheal deviation. So it's gonna literally, you're gonna palpate and your hands will go like this because your trachea is gonna be pushed to the left because it's all that pressure from the air. It pushes to the left. Or if it's on my left side, it's gonna push to the right. Okay, so those are some palpation strategies or some criteria that you're gonna be using. The other thing that we palpate for is spine. Did you remember in your PowerPoint we talked about scoliosis, lordosis, kyphoscoliosis? So basically, you're going to feel your patient's spine to make sure we want it midline. Okay? Okay, so that's palpation. Percussion is where we tap on our patient's chest. Usually doctors do that for you. As a respiratory therapist, you guys, we do not do a lot of percussion, but it is on your boards, and so we're going to teach that. Okay? And the other thing is auscultation, meaning using your stethoscope, okay? Has everybody in here ever used or know how to use a stethoscope? No. Okay. So, we have what we call our ears right here. Do they go forward or backwards? They always go forward, okay? When you put your ears in, they go forward. Now, you guys, when you're using your stethoscope, this turns, okay? This side is usually for like high-pitched sounds. We like to use the big diaphragm side. And you always know if it's working is when you put your ears in, your stethoscope in, tap gently. So I have it on the right side. If I turn it this way and I tap, so if I tap this side, I'm not going to hear anything. So you can just start turning. Okay, can you see the difference? Be nice to your partners. Don't go up and just like wham on their diaphragm because you're going to hurt their ears. Okay? And the other thing I want to show you guys is I was on the neonatal transport team in pediatrics. So there's different size stethoscopes. Stefan, can I see that stethoscope?
Yes.
I just want to show you guys the difference in the bells.
Smaller.
Okay? And I actually have, let me get one more. Where's the other one? Okay, you guys see the difference?
Oh, baby.
3 different sizes. Okay? Neonatal, pediatric, adult. If you use this on a neonatal baby, it will literally cover their whole chest. That's how small they are, because they're preemies, okay? Again, neonatal, pediatric, adults. Okay? So when we're in here, we're all adults, we need to use the right size stethoscope. Okay?
Yeah, so what would happen, like, what happened if it's a small one on an adult heart? You just can't get, like, a whole picture?
You wouldn't hear as much as you should because of the surface area. Look at the surface area on the tube.
Yeah.
Okay.
Sure.
Okay? The other thing is with these is, you guys, when you're listening to your patients or to your partners, I want 6 areas. 6. Count them. 6. 1, 2. What are these called? Upper, lower? Upper lungs, also known as apicals. So here. I don't care if you go left, right, or right, left. We always go across, because why do we do that? Why don't I just listen here, and here, and then go here, here?
Different sounds and different small lungs.
Right. I want to compare my lung sounds, right? I want to compare my left upper lobe to my right, other way, left upper lobe to my right upper lobe. Because guess what? We have to chart on that. Okay? So left upper, right upper to left, medial, and then lower. Lower is not down here. Okay? If I put a stethoscope here, you're going to hear what they had for breakfast, if they had breakfast or not, okay? This is their stomach, okay? We don't care what they had, okay? If they didn't eat, you're going to hear nothing but growling. Now, back here, you get really low, you're either going to hit on the kidneys or the liver. Okay, one way to find the lower lobes in the back is feel for the bottom, the floating rib of the rib cage, okay? And then put your stethoscope there. Here, same thing. This is where my stomach is, because your rib cage goes like this. So if you put your stethoscope here, you're on their stomach. So we're over here, okay? For women, it's right below the breast, okay?
That's for lower.
Lower.
And where's the middle again? That would be like a
You
little
do
bit-
medial right about here, okay? And then your lungs go way up here. Remember, our lungs grow according to our height, not our width, okay? So, if I'm going to listen to somebody, who wants to be my patient? Okay, you got to take your sweatshirt off, though. You guys, if you have sweatshirts on, please take them off, because you're not going to hear anything with your, doesn't matter how good your stethoscope is, you're not going to hear anything through a sweatshirt, okay?
So you'll do upper, lower, and then medial to medial.
Yep. You want to come over here, Sheridan? So when I am listening to my patients, I ask them to take a deep breath. Here's the deal. A deep breath is this. It's not this. Because if your stethoscope is on your patient, what are you going to hear if they're doing this? That's all you're going to hear. So a deep breath is just a little bigger than a tidal volume. It's, okay? And I usually ask for 2 breaths. So my ears are in, forward, right? You'll know. If you put these things in backwards, you'll know. Okay? So, up or low, big breath. Again. That was 6 sounds, okay? Now, you can do it on the back if you feel more comfortable. You can do it on their back. And again, on the back would be 2, 2, and 2. And I was comparing lobes, okay? Questions on that? Now, do we really know lung sounds yet? Not yet, you guys don't, but you will, because right now, hopefully everybody in here has normal lung sounds. So we should know, we should be listening to everybody and hearing normal. If you don't hear a normal breath sound, which is just a whoosh of air, it just kind of sounds like just a normal breath sound, that is normal. If you hear any kind of squeaking, any kind of crackling, any kind of, if anybody has a cold or any kind of secretions, you're going to hear like a rustling. Those are called rhonchi, and that's secretions in your lungs. But right now, everybody's pretty healthy, so you should just be hearing normal breath sounds. And how do we chart that? Normal breath sounds. Anybody know?
Oh, you said it earlier? European.
Okay, that's what we call normal breath sounds, right? So if I go to chart, your options are diminished, clear, good aeration, rhonchi, wheezes, stridor. So you have all these options when you go to chart. When you, clear is a normal breath sound, okay? So if we're all clear and you can hear good aeration, it's going to be clear, okay? Okay, everybody good on breath sounds so far? We're going to learn more about breath sounds later, probably in about 2 weeks. I just want you guys to get used to hearing normal breath sounds and getting your 6 areas of where to listen. Okay? Cool. All right, so now we're going to do our competency. Ooh.
And this video, will we be able to watch it on Schoology? Or
Sure.
Wonderful.
Okay, so who wants to be my patient? And who wants to be my reader?
I'll be the patient.
Okay, hop in bed. You guys, on your competency, it's on page 105 in your book. 105 in your Butler competency book. Okay.
Sorry.
So here's the deal. When you do your competencies, even when you're in the hospital, and say I'm 6 foot tall, she's really low, right? Please feel free to raise the bed, right? You just got to have the railings up. Don't kill your back. Put your back out by doing an assessment. Whenever we do an assessment, guys, what kind of position do we put our patients in?
Or semi-follow.
What is that, Stefan?
Semi-fowler.
Semi-fowlers or a fowlers? What is a semi-fowlers compared to a fowlers? Anybody know?
Semi-follower is probably 30 degrees, and then follower is sitting up
Close.
completely straight.
You're really close. You're so close. Let's see if we can get this up into a semi-fowlers.
45?
This bed may not. There we go.
There we go.
Semi-fowlers is a 45 degree. You were close with 30. Okay, so is this about 45?
Yeah.
Okay. A fowlers or full fowlers, straight up. You guys, you always also ask your patient if they're laying flat for a reason, because the last thing you want to do is have your patient just having spinal surgery and you go in there to do an assessment and you put them in a fowler's position.
Yeah,
Right?
that'd be terrible.
Wouldn't that be terrible?
Yeah.
Okay, so are you feeling okay? You're like, I'm really straight up here. Okay, so I am going to go and do an assessment on her, okay? Now, guys, you have to remember, when you're in the hospital, our assessments are not going to be in detail as these, okay? when we go in and do an assessment, if you're called for a respiratory assessment, you're going to go in and you're going to evaluate their heart rate, respiratory rate. You're going to listen to them. You're going to look at their oxygen saturations. And they're going to ask you, why is my patient desatting? What do you hear? What's going on? This one that we're doing right now is very detailed, okay? We're going to get into some modalities here that we typically will not use on an assessment, okay? So the first thing that I'm going to do is I'm going to wash my hands, right? Okay, and then I'm going to put some gloves on. Please put gloves on to touch your patients if I can. I don't like
There's
gloves.
more over here.
Is there any smalls over here? Here we go. Okay, so I washed my hands, put in my gloves. So, who's my reader?
I'll be the reader.
Okay, so what is the first criteria?
Common performance elements, steps 1 through 8.
And what are those steps 1 through 8? Do you guys remember?
Isn't that like look at the chart?
Yes,
chart,
very good. Yep, steps 1 through 8 is you've washed your hands,
You introduced yourself.
you've introduced yourself, you check the chart. We always check the chart before we go in, right? So I've done 1 through 8. I've checked my chart. I've brought in all my supplies that I need. I've washed my hands. Okay? I basically know why my patient is here, right? Because it's in their chart. You know what their chief complaint is, right? Okay.
And you know if you need to put PPE on, what kind.
Yep, and you'll know if you need standard precautions, airborne precautions, droplet, whatever it may be, negative room pressure, anything like that. Okay, so what's next, Cynthia?
Assessment and implementation. Number 2, common performance elements, steps 9 through 10.
That's the same thing. We've already done that.
Oh, hold on.
But included in
Sorry.
that is what?
Okay, so we're gonna observe patient for overall appearance, age, sex, and weight, notes, patient positioning, tripod, high fowlers, etc. Stands directly in front of
Okay.
the patient and observe chest for shape and appearance, anterior, posterior, diameter, sternal deformities, surgical or other scars, and symmetrical expansion. Observes for normal.
Okay, so let's just go criteria by criteria.
Oh, sorry.
I'm just going to demonstrate each criteria.
Okay, sorry.
So
Okay.
I've checked my chart, washed my hands, put my gloves on.
Yep.
I know that she's a female from my chart.
Yep.
So I walk in and I say, hey, I'm Jackie with Respiratory. I've come to do an assessment on you. Take your wrist. Can I touch your hand and check your patient ID?
Yes.
Always ask to touch your patient. Just don't go in and start touching your patient. That's in their space, comfort space, okay? And how about this? Somebody do it today. Right? Is that like the worst thing you could ever do? Or for me, I'd have to be like, hey,
Sit on the bed.
you guys never sit on the patient's bed, okay? Okay. You guys laugh, but I've seen it.
It happens.
Oh,
It happens a lot.
it's so
Okay.
sad.
Always have fun in lab, okay? Okay. Patient identifiers, what am I looking for? What am I?
Date of birth.
Date of birth and
name.
name. So what's your date of birth?
11/16/81.
And your name.
Dusty Smith.
And Dusty, what do you like to be called?
Dusty.
Okay. Always check to make sure that you are calling your patient by the right name. Some of the geriatric population may want to be called Mr. or Mrs. Some people, or from whatever culture they're from, maybe want to be called, they may want a formal name, okay? So just don't assume that it's by their first name, okay? Okay, so I've done my patient identifiers, I've confirmed my name, now what else?
Note patient's positioning.
Okay, so guys, one of the other thing is always leave your patient in the position you found them, okay? So if I found her in a semi-fowlers or fowlers, I'm going to leave her in that position, and always put your bed railings back up. The last thing you need is for you to leave your railing down and your patient fall out of bed. Guess who gets in trouble for that?
You do.
Okay, so, but when you're doing your assessment, you can put your railing down. Just remember to put it back up. Now, if I walk in and she's laying flat, and maybe she just woke up or something, I have already checked her chart and I know why she's here. So I know she can be in a semi-fowlers or a fowlers position. I know she just didn't have spinal surgery, so I'm not going to put her in a position where she can't move. Okay? So I have her in this position, and I am looking at her. What am I looking for?
You're observing her chest.
I'm looking at her chest
shape.
rise and fall. I'm looking for any kind. I can do a lot of these at one time. I'm looking for cyanosis. I could be like, hey, can I see your hand? And I can do a cap refill. What should my cap refill be?
3 seconds.
3 seconds. Kind of hard. She's got some nail polish on, but I can see. What's another area that you can do a cap refill on?
Her toes.
Her toes or her earlobe. Okay. So I'm looking for cyanosis. Her lips are not blue. I can't see them, but they're not blue under that mask. She doesn't have acrocyanosis, right? So I know she's got good perfusion.
Can I ask a question?
Sure.
Cap refill. What?
Cap refill is, it tells us her perfusion. So you will press the finger, and you want to refill anywhere more than between 3 and 5 seconds. 3 seconds is really what we're shooting for. So when you press down, it turns white, you let go. We're going to see how quickly it pinks up. That's your perfusion. Okay? So I'm looking for any kind of lesions. I'm looking for any kind of scarring. Maybe she's got stitches. Because the last thing I want to do is if I have to do a modality or a treatment on her, the last thing I want to do is start pounding on stitches or scars or whatever it may be. Okay, what else? So I'm looking at what happens if she had barrel chest? That's the one thing you can look at. So she had barrel chest. What's barrel chest?
Deep chest. Like in it.
My diameter of my chest is really big. What disease process is that? Have you guys gotten with that with Jamie's class yet?
No.
COPD.
Barrel.
Barrel chest. It's when the diameter of the chest increases. It's because your COPD patients are using their accessory muscles to breathe, and they're deep breathing all the time, and they're sucking in air, and they're in a tripod position like this. Their chest, the diameter of the chest, gets bigger. Their rib cage actually expands out. Okay? That's called barrel chest. When you see it, you won't forget it.
Is it because like their accessory muscles are like essentially?
They're using their breathing, accessory muscles to breathe. So these get really big. They'll have big shoulders because they're usually tripoded. And so when they breathe, we breathe normal. When they breathe, they use their accessory muscles and their shoulders to breathe. So they're like, because they can't inhale and they can't exhale very well. So they use all their muscles to breathe. The only muscle we use to breathe is what? Our diaphragm. They have to use every muscle just about in their upper body to breathe. Okay, so I've looked for barrel chest. She doesn't have barrel chest. What else?
You did the cyanosis. Observe for presence of chest tubes.
So she had a chest tube. It would probably be coming out one of these sides.
Or both.
And it would be to a suction system on the bed. Meaning she had empyema, which is pus in the lungs. And we had to put a chest tube in and drain it. True story. As an RT, you get to assist in putting chest tubes in. It's kind of cool, kind of not. I was assisting putting a chest tube in with Dr. Banks, and the nurse we were cutting, making an incision, and so you have this this tubing that goes to this big suction. Well, the nurse was supposed to be hooking up the suction to the container, and I was standing like right here, and I was assisting, and she forgot to put the tube into the suction.
God.
So as soon as we put the tube in, all that pus and blood went all over my shoes. I am not kidding. I was like this. We got a problem? And the Dr. Banks was like, Jackie, don't you move your hand. Don't you step away. Because I was holding the tube. He's like, just leave it drain. And I'm like, okay. Meanwhile, it's going all over the floor, all over my shoes. True story. I was just like, So,
I got the tube.
moral of the story is don't move. You just hold that tube and you just suck it up, guys.
Yep.
Okay? So you're going to check for chest tubes. The other thing is to always check because that container sits right on the end of the bed, like on the side of the bed. And you don't want to go and kick it. If you don't see it, you might kick it. So, and you should, where would I find out information that they have a chest tube in?
In your chart.
In their chart, right? So, always make sure you know if they have a chest tube. So she does not have a chest tube.
Okay, you did the no, you didn't. I'm sorry. Hold on. The scars. Okay, observe normal or abnormal spinal curvatures.
Okay, so what am I looking for? Spinal curvatures. What are some spinal curvatures? What are some diseases deformities I'm looking for?
Scoliosis.
Scoliosis, which is
Curvature.
okay. So what I would say, hey, could you sit up for me, please? All I'm going to do is I'm going to put my hand at the top by the spinal process, and I'm going to just run my hand all the way down her back, feeling to make sure that her spine doesn't have any kind of curvature. Okay? What else?
Paradoxical or unequal expansion.
Okay. This I can look at. You can sit back down. This I can do on inspection. Paradoxical breathing. What is paradoxical breathing?
It's when she breathes in, it goes in, or no,
One side?
it's the opposite.
It's the opposite of what we do, right? So think of this. When you take a big, deep breath in, where does your stomach go?
Wow.
Out, right? Because what is happening? What's happening to your diaphragm?
It's expanding.
Your diaphragm is pushing down so your lungs can fill up, right? So I take a big, deep breath in, my stomach goes out, my diaphragm goes down. It allows my lungs to fill up, correct? Paradoxical breathing is the opposite. Okay? Typically, your diaphragm really doesn't move, and instead of my stomach or my thoracic cavity going out, on paradoxical breathing, it's going to go in. It's going to do the opposite. And that's usually due to some kind of trauma that they've had. So we call that paradoxical breathing. It's the opposite of normal breathing. I see Stefan over there going, okay? That is paradoxical breathing. So I'm looking at her. Stomach's coming out as she takes a big breath in. Okay? What's the next one we have there, Cynthia?
The last one of that group would be observe the skin for cyanosis, pallar modeling, diaphoresis, diaphoresis, swelling, pitting edema, turgor.
Who knows how to say that?
Turgor.
Very good.
Thank you guys. Dryness, bruises, arrhythmia, and Paradoxical. I don't know.
Who knows how to say that?
Pechier.
What is it?
Pechier or something.
Petitia.
There it is.
Petitia?
Yep.
Petitia. That's
Okay.
French.
So what is modeling? Modeling is a perfusion issue that patients have, and it's usually it's just like redness splotches all over their skin. And unfortunately, it's associated with congestive heart failure, and it's usually end of life. Okay?
So
But it's a perfusion issue. You just, because they're not perfusing anymore.
So the skin becomes a different color too as well,
it
right?
gets red mottles.
Okay.
We call it modeling. Okay?
Red splotches on the skin.
Yeah, like blotches. What else do we have? Oh,
Diaphoresis.
diaphoresis is what? If I'm diaphoretic, what am I?
Sweating.
Sweating, right? I'm sweating. What's another one?
Swelling.
What is pitting edema? What's edema?
Nails,
Let's
right?
break this word down. What's edema?
It's like
Swelling.
swelling of the fluids in
fluid
your
buildup.
skin.
Right, it's fluid. It's usually associated again with a heart problem, right? Or we're
Kidney problem.
kidney, we need Lasix or something. So we have we're fluid overloaded, we call it. So where does the fluid go if you're standing up?
Extremities.
To your extremities.
Right? Gravity takes it down. So Dusty could have huge ankles, right? And like you can see her bone here, but if she had edema, they would be huge. And you can kind of see that. You kind of see it when people are out and about.
Yeah.
Pitting edema is if I touch it, it makes a pit. It's- Okay, so literally she's all swollen. I touch it, and she's got a big divot in there. That's pitting edema. Stefan, your eyes are this big.
It's like memory foam.
Memory foam? Okay.
Your skin.
I have pitting edema on one of my
Do you?
Yeah, because I have bursitis.
Well, there you go. Okay.
on one foot. So
Precisely.
I call it my Mr. Deeds foot.
You're Mr. Nice. Okay, now the other thing that we look for is, especially in, how would I know if somebody's dehydrated? What is a quick way to know if you're dehydrated?
You pinched her skin.
And what did you call it? Starts with a T.
Is it the term?
The turgor.
So, I take her hand, and I want to see how fast it goes back down. Okay? All you're doing is lifting the top of the hand. That's to check for dehydration.
Like the elasticity of
Yes.
it?
But if she was really dehydrated, and I pinched her like this, literally her skin would still stay up because there's no fluid in there. She's has a low fluid volume. Okay, so that's checking for dehydration. Okay, so that's another one, and then so a lot of these you guys can see that we can kind of go through. You can do it, or it's observation. Okay. What's the next criteria?
Can you
I'm
say
sorry.
what petechiae is?
That's red. That's just red spotting all over. It's different than modeling. It's just like little red spots all over.
Oh.
Okay. It almost looks like a rash. Okay.
Observe skin for any masses, lesions, or nodules.
Okay. So I can look at her and see if she's got any nodules or lesions or any of that. Okay.
I have a question real quick.
Sure.
On the other one, what was the
Arrhythmia.
arrhythmia?
What's arrhythmia? What is that?
Redness?
Red blood cells, right? So it is a lack of red blood cells. It's anybody that's probably anemic is lack of red blood cells. So what's her skin gonna look like? Do you think?
Pale.
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 Okay.
Mhm. And on there it says, I think it says pallor too. Just means pale skin
Okay.
due to a lack of red blood cells.
Okay.
Okay. Good questions.
Next one is assess respiratory pattern, regulatory rate and depth of breathing, and accessory muscle use.
And this is inspection too, right? I can see does she have a normal breathing pattern?
Yeah.
Yes. And what's our normal rate?
12 to 20.
12 to 20. Okay, she's breathing normally. She doesn't have biots or blots, as Cynthia likes to say. So we don't have biots, we don't have Shane Stokes, and we don't have Kussmaul. Okay? So she's got a normal respiratory pattern. Her tidal volumes are normal, right? She's not hyperventilating where she's taking these big volumes, right, and blowing all her CO2 off. Okay, so I'm looking at her and I'm like, good respiratory pattern. Now when you check off, I may kind of whisper to your patient and say, shallow breathe, okay? Or I may say, hey, let's do a little Shane Stokes, okay? So just be aware, you're going to have to look at their breathing patterns, okay? So we learn those breathing patterns, don't forget them because you need to put them in your file cabinet in your head and just keep going with them because we use them in the hospital all the time. What else you got?
So next we're going to evaluate for orthopnea, platypnea, and pleurodynia.
Okay, so those are all those breathing, right? So she's breathing. If I had her flat and she was having a problem breathing, laying flat, what could I do?
Sit her up.
Sit her up, and she's fine breathing, and that is called?
Fowlers. Semi-fowlers.
Orthopnea?
Eutherpenia.
Put her in a Fowler's position, now she can breathe. It's called orthopnea. Correct, you guys are right. Okay? So make sure you know your breathing positions.
What's the pleurodynia?
I don't think we have that one. Yeah, we didn't.
We're not going to, you can scratch that one off.
Okay.
Sorry, guys.
So would you go through all of those sections and check for everything, like all two of those?
Mhm.
Okay, wonderful.
Yep, correct. What do we got next?
Palpate positions of the trachea.
Okay, so you guys, the same time that I'm going to palpate her trachea for tracheal deviation, I'm also going to check for sub-Q. Okay? So basically, here's the deal. If your patient can sit on the side of the bed for these next couple of ones, that would be great. Okay? So for tracheal deviation, I usually use 2 fingers, and I'm just going to go along the trachea, and I'm just going to press gently, and I'm going to feel to make sure that her trachea is midline. Midline means
In the middle.
right down the middle, okay? The other thing, now I've checked here, and I'm just going to put my hands right on it. It's all one, right? Tracheal deviation, good, none. And then I'm looking for crepitus. or sub-Q? Sub-Q is air, again, that has been in a thoracic cavity and it's under the dermis layer. When you touch it, it feels like Rice Krispies. It literally will feel crunchy. Okay, because that is air in the tissue. So it's like little air bubbles in your tissue. So when you touch it, you can kind of crunch them. Okay? Once we get rid of a pneumothorax, we can, the air will dissipate and move out. Okay?
The next one was subcutaneous.
Okay, and I
we're
did that all in
palpitating
one.
For that.
Yep.
And then we palpitate for bilateral chest expansion.
Okay. This is where you can do the spinal curvature and the chest expansion all in one thing. Okay? So basically, this is called chest excursion. And what I'm going to do is I'm going to put my hands on her back. And then I'm going to have her take a big deep breath in. Here's my spine. Okay? I'm going to put my thumb, both thumbs on each side of the spine, and then I'm going to spread my fingers like this. And then I'm going to kind of grab her back, but not real hard. And I'm going to say, take a big deep breath in. When she does that, my hands should move with her. Okay? Because I'm kind of holding on. So she takes, so this is her back, and I say, and here's her spine. Big breath in. My hand should move. You want to see equal symmetry between both thumbs. Now, what happens if I had her take a big breath in, right? And it went like this. This side didn't move.
Unilateral breathing.
Bilateral.
I got something going on unilaterally, right? This side did not move. Something is wrong on the left side. Okay? What happens if a big deep breath in and I went like this? Something's wrong on the right. Or you may have this. This one may move a lot and this one may move a little bit. Okay? Basically, it's probably consolidation, a pneumonia, or something's going on where they can't oxygenate. They can't take that big deep breath in that lung. So I'm going to show you how to do it on her back. Can you please swing your feet over the bed? Okay. So basically, can everybody see this? Can you stand up so I can just demonstrate this real quick? So I look for the spine right here, right? I put my finger on her spine. I'm going to put a thumb here. Now, you don't want your thumb on the spine. Right next, and the other one here. You kind of want to grab a little bit. Put your hands flat. Okay? Now, I'm going to say to her, take a big, deep breath in. Do you see how my hands just move?
Yeah.
Do it again. You see that?
Yeah.
Now, another big, deep breath. Now, if this side didn't move and this side went like this, she'd have something on this. When you do that chest excursion, you can also at the same time do your spinal check too. Okay? Now, I have her up, I have her back. We have two things. Is it tactile firmitus next?
Yep. That's actually in between the chest and the spinal curvature.
Okay. You guys, I'm going to tell you something. The way you do your chest assessment, you don't have to do it in the order I do it. Okay? I have my own way of doing this. As long as you cover all this criteria, I'm okay. Okay? I've just been doing this a long time, so I know
You have your own routine.
I have my own routine, which is cool with clinicals, because when you go to clinicals, you're going to have a different preceptor all the time, and they all have different ways of doing stuff. So you may say, I don't like the way they do it, I don't want to do it that way. And then you may be with another preceptor that does it just, has this great routine. So you get to pick up different styles from everybody. In here, Amy and I and Jamie will show you different ways of doing stuff, but you do whatever works best for you, okay? Because you got to use it in the field, so I'm on the back. What's tactile firmitus and vocal firmitus? Does anybody know? Any of my guys remember?
Tactile is touching.
The vibration.
Right? It's a vibration, right? So we have tactile firmitus and vocal firmitus, okay? Basically, it's it's a voice that creates a vibration. That's your vocal, okay? So when I talk, the vibration from my larynx goes through my bronchotracheal tree and creates a vibration. That is vocal firmitus. Tactile firmitus is you can do it two ways. You can put your hands like this. You can put your hands like this. Tactile is you hear that vocal firmitus vibration. Does that make sense? So you can go like this. You can go like this. I usually just do this, and I say 99.
99.
Again.
99.
And I literally can feel the vibration right here in my thumbs. So that is vocal firmitus. Tactile is, I'm sorry, this is tactile because I can feel it. Vocal literally is when you have them say 99, the vibration goes through the larynx, through the bronchotracheal tree, creates a vibration, and then comes out tactile, and you can feel it with tactile firmitus.
So they're kind of hand in hand, the vocal
Yes.
and tactile. Okay.
Okay? I can't do tactile firmitus without her doing vocal firmitus, right? So the thing is, can you please say 99?
99.
And you literally can feel the vibration. Now, what happens if I had her say 99, and I could feel it on the left hand, but I couldn't feel any vibration on the right?
Maybe there's a
I got something going on the right? I might have a lot of consolidation in there, and that vibration can't get through all that consolidation. So that is tactile firmitus and tactile and vocal firmitus. Okay? So I would say when you're doing your chest excursion, you're doing your spinal curvature check, you can go right into tactile and vocal firmitus.
So to repeat what you just said,
Yes.
the tactile firmitus is to the larynx, to the tracheal bronchial tree, which create a vibration when your hands are
Right.
here.
That's vocal.
Oh, vocal.
Vocal is so when she speaks vocally, right? Okay, listen to what I'm saying.
Okay, sorry, I'm confused.
Okay, this is confusing for everybody. Vocal firmitus is when you have your patient say 99. That speaking, that vibration in your larynx, when you say that, it causes a vibration in your larynx, which goes through your bronchotracheal tree. That's vocal firmitus, the vibration from you speaking. Tactile is you feeling it on her back.
Feeling, okay.
Make sense?
Yes.
Vanessa, you're looking confused.
No, it makes sense.
Okay, I just can't tell with your mask. I can't tell. This mask is hard to see your facial expressions to see if you're. Okay, does that make sense now?
Yes.
Is there other words you have them say? Like,
You can basically have them
Anything?
talk anything. You can go say 1, 2, 3, 99. 99 is just a good one because it gets a good vibration.
okay.
Okay? So you could do the spinal curvature, the firmitus, and then your chest excursion. Okay, what's next?
Palpitate pulses and assesses capillary free
We
flow.
already did that, remember?
And then perform diagnosis of chest percussion.
Okay, guys, chest percussion. This is a hard one for people to do. We typically don't do this. I think when you go to the doctors always pound on you. We as therapists, we don't do that. But it's on your boards, so I'm going to show you what it is. So what's in our lungs? Air, right? Our thoracic cavity, it's a lot of air in our lungs, right? So if I have clear lungs, what kind of sound do you think it's going to make? A hollow sound, right? So, can you turn around, please? So you take your two fingers and you do this. Okay, so I'm right here. It should sound hollow because there's nothing but air in there. And the way to tell the difference is do your thigh. Hit your thigh, and it's going to be like a thud. But if you do on yourself, do you hear the difference?
Yeah.
Okay, so you do it on your thigh. Your thigh's meaty, full of muscle, right? Up here it's hollow, so we want to listen for a hollow sound. Okay, now if I went like this and I got like that dull sound, what do you think is going on?
There's like fluid.
Fluids in there.
Fluid, pus, blood, anything will be in there because it's not hollow anymore. There's something inside the lungs. So basically it's, okay? Hear the difference again. Tap on your leg or tap on yourself on your own chest. Kind of weird. And you can hear the difference. Okay? So that's percussion. What's the last one?
Our last one is
Auscultation.
for normal, abnormal, and adventitious breath sounds.
Okay, what does adventitious mean? Big word for
Small.
abnormal, right? That's all it means. Adventitious means abnormal lung sounds. Okay, so that would be wheezes, stridor. The easiest breath sound that you'll ever hear is stridor. If your patient has stridor, you will hear them from the door. Stridor literally is. It is basically their epiglottis is closing. Okay, so the air can't get through. Epiglottitis will cause that. Tracheitis will cause that. It's called stridor. Croup sometimes will cause that, inflammation of the airways. We give corticosteroids for that to get the inflammation out. But if somebody has stridor, you will hear it. They literally will be, because they can't get air in and out. They're having bronchospasm.
Would you also say stridor is if someone was choking on something? Would that also be stridor?
If you have a foreign body stuck, it can cause stridor. Yes.
Okay.
If you have foreign body aspiration, which is something stuck in your trachea or in your lung, it can cause stridor too. Okay, that is a sign of foreign body aspiration. Good question. Okay. Our last one that we're doing is what? Auscultation or breath sounds. And how many areas am I going to listen to? 6. So, you want to hop back in bed? I know it's really high, sorry. Okay. Again, which way do my earpieces go? Forward. Okay. Checking. Okay. Big breath. Again. 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 Okay. Good. You're really clear.
Glad.
So if you sit up, guys, if you feel more comfortable, especially Stefan, because you're male, you can do the back. 2 uppers, feel free to do the back. Okay, you guys, and I'm serious when I say this. In the hospital, if you're a male and you're doing breath sounds, yes, have your female sit up and try to do the back. Okay, protect yourself. And I'm being totally serious when I say that. Because some women, for one thing, won't feel comfortable with a male listening on the front. Okay? So, and don't be offended. If they say something, just go straight to the back. Okay?
Yeah.
The other thing is when you're listening to breath sounds, make sure that you're keeping your diaphragm totally still. Because if you don't, you're going to hear rubbing. So you got to kind of press on your patient. I recommend when you're in the hospital, we always go to the skin to listen. But if you have to go over clothes, a lot of times you'll hear the rubbing of the clothes. So just be aware of that. Otherwise, you're going to be charting like a pleural effusion or something when they really don't have it. Okay? So that is basically it. Am I correct?
Yep, that's it.
So then when you're done, guys, you're going to go and you're going to chart on all your findings. Okay? Again, you guys, as long as you hit all the criteria, it's all good. Okay? You don't have to do it in the way that I did it. Figure out figure out the best way for you to remember all this, and then go from there. So you guys get your partners, get in your beds, help each other, trying to remember and missteps. Again, when you're checking off with me on a competency, I will try to get you there because this is a lot to remember.
Yeah.
Okay, so I will present questions to you, critical thinking questions to you, to get you to get all your criteria in. Okay?
Okay.
Everybody okay? Questions? Concerns?
We're just going to be practicing.
Yeah.
You're just going to be practicing right now.
Okay.
Okay? Please wear gloves when you're touching your patients.
Would it be easier to, like, when you're observing and palpitating from literally head to toe instead of just going all over the place?
Yep.
Okay.
However you want to do it.
Okay.
Now, when you do your competency and checkoff, some people are like, do I have to talk you through it? No.
Okay.
I'll watch you.
Okay.
But if you feel more comfortable, because somebody's like, well, I need to talk through it as I do it, that's fine. I'm good with it. Okay? Questions?
So when we do our actual assessment, that first one where we have the other previous 8 steps, do we still go through
Yeah.
those 8
So you guys, good question. You guys, when you start your assessment, you're going to tell me, I've checked the chart, I've washed my hands.
Okay.
So you're going to tell me that part.
Okay.
Okay? And then you still introduce yourself and you still do your patient identifiers.
Okay.
Okay? Cool.
Would you like for me to do a patient first? Or?
Yeah, because I already have my gloves on.
Okay.
When are you watching this? Like, when do we have to have this checked off by? Next week or?
I'm going to give you 2 weeks on it.
Okay.
Okay, good.
You need time.
And this is already on video for.
Yep.
Okay, what?
For the checkoff.
All right, wonderful.
You guys just remember that even after class, on days that you're here, we have like 3 labs. They're all open. You guys can come in. This is your time, and if the labs are open, they're your labs. Come in here and practice. Okay?
Well, I wash my hands.